cancer, which we need to exclude before we move any further. And of course, risk of prostate cancer, and the rest is standard. Medical history, medications. On examination, the general looks of the patient. How did they struggle to get into the chair, out of the chair, shuffling gait, uremic? Did they have a palpable bladder? Did they have any wet pants? Do they have any phimosis or meatal stricture that indicates what's happening? When they ask them to cough, do they leak? And of course, a DRE for people who are comfortable doing DRE. Part of the cornerstone of managing these patients is the bladder diary. That gives us more of a robust information about what's their drinking habits and how do they wee. Because did they drink 10 coffees a day or 12 beers a day versus do they have a small capacity bladder and every 50 mil they collect, they have to go and wee. Urine for infections, bloods, and an ultrasound are useful. We would love to have a bladder diary each time we get those patients in the clinic because that will be a very important tool and save them a second visit. Now, how do we manage them? Will be a very simplified approach, but we first need to know if there is any reversible causes. Do they have a urinary tract infection? And when they treat it, that's good. Do they have a cancer that you need to treat first and foremost? Do they have a bladder outlet obstruction that when you fix, their storage problem becomes a lot better? From there are 4 stages, 4 steps of management, which is lifestyle changes, medication, minimal invasive, and maximum invasive therapy. The first line is the lifestyle changes. Stop smoking, weight loss, fluid management, and avoiding irritants. Simple, approachable, done in the clinic, and has a magical effect. Ural helps alkalining the urine and make the urine, holding the urine easier. And there's so many other management options for that lifestyle changes. Bladder retraining is a key aspect as well, because if they have high post-void residual, the bladder, when it pumps like a heart and finishes up, it gets tired after a minute or so and will not be able to pump anymore till about 3 minutes later. So what I tell them is that you wee, you finish, if you go, you wash your hand, you brush your teeth, just wait 3 minutes and then go again, because there is no point of staying on the toilet for a long period of time. Time void, if they have a problem rushing an urgency at a certain volume, if they time their void every 2 hours before they reach to that point is important. And from there, having a pelvic floor physio near you would be very useful for pelvic floor exercises and urge suppression. And really some of those needs a management plan because there are so many other aspects of their care that we can need coordination. From there, the second line is medications. Anticholinergics and the beta agonists are the staples of our treatment. Anticholinergics just relaxes the bladder and stops the bladder from spasming. It comes in tablets and patches and it's MBS funded. The problem it gives them is dry mouth, dry eye, and constipation. The patch itself has some itchy and less side effects, but does come with some people, most of people complain of itchiness. It carries a risk of acute urine retention, especially with high post-void residual people, and need to be careful about that. But the less known, but however very important side effects of this is cognitive impairment. Because as a cumulative effect of anticholinergics, in that particular group, which is mostly elderly people, it has a devastating effect. It can turn someone who is mobile and active to, a couple of steps closer to dementia, which could have been avoided. We start low with 2.5 milligrams BD, and then we increase up to 5 milligrams TDS if well tolerated. The alternative, which is my favorite, is beta agonist. It has a lot less side effects. It can cause hypertension and tachycardia, And it takes 4 weeks to take maximum effect. So they have to stay with it, not take 2 tablets and, oh, it didn't work for me. But the major problem, it's not MBS funded, and it costs $50 a month. And that's a lot for most of our patients, which are most of them are retirees. But we should discuss the options with them. The next step in the management is cystoscopy and Botox, which is a cheap, reliable option that most urologists can do even in their clinic under local or under general anesthetic. It does work, but it carries the risk of the cystoscopy, and it does wear off after time, 6 to 12 months, and needs another operation. The bigger other alternative is sacral neuromodulation. And despite what most people think, it's an equivalent third line that should be used, but requires a urodynamic prior. It costs about $5,000. It needs to be under specialist care. It's 2 operations. One is a trial of implantation of the wires, and then the implantation of the device. But that carries you usually about 5 to 6 years. With both options have similar success rate. And the 4th line is surgery, bladder augmentation, borrowing some of the bowel to patch the bladder, increasing its capacity, or urine diversion altogether. But that's a whole different ball of fish that usually as an end stage final option. With that, I finished my talk. I hope I was within time. And I'm happy to take any questions, or would you like to carry on the questions after Mr. Al-Samurai has his talk?
Thank you, Dr. Muttalib. Very, very quick, very good, and to the point. I do have myself a couple of questions, but perhaps because I can see that Dr. Ahmed Samurai has answered a couple of important questions from the chat. Thank you, Dr. Ahmed. I suggest that we proceed with the other presentation, then we leave another 10 or 15 minutes in the end. We have half a dozen of questions already. So thank you very much. Dr. Ahmed, can I share the screen? Can you request a share screen with me, please?
Yes, sure. Thank you. Yeah. Share. Is my screen coming up now?
Perfect. Yeah, I can see your screen beautifully.
Thank you, everyone. So I will talk about a wonderful presentation from Dr. Al-Shawi himself, who gave me this wonderful presentation to share with you guys. It's about hematuria and hemorrhagic cystitis. So hematuria is defined by red blood cells in the urine. This could be visible or invisible, and most patients now would rather understand those 2 terms, visible and invisible. Classification, it could be sourced from the kidneys, so it's from the parenchyma, or it could be from the urinary tract, down from the pelvic calyceal system, ureters, bladder, prostate in men, urethra, and so forth. It also can be mixed up with menstruation and could be in men related to their foreskin problems. It's not uncommon. 1 in 100 of pediatric population, somewhere around that number would have it. Adults, 5% would have some degree of invisible or sometimes visible hematuria. And 10% of those who are above 50 years of age. You can see from this picture that the microscopical type is not serious, and it's probably is not as important as the visible gross macroscopical hematuria. The evaluation would be based on these 2 different distinctions. And the chance of cancer arising from hematuria is much more important in the gross type. So 18% of those who had macroscopic hematuria will ultimately have a cancer of some sort or a pathology of significance. And yes, in a large number of patients, we do not find a cause. We investigate with cystoscopy and imaging modalities and fail to find a reason for the microscopic hematuria. For macroscopic hematuria during the acute episode, it's hard to believe you couldn't find the cause, because you will go in with the intention to lateralize the hematuria from either ureters or from the bladder or prostate or urethra. Cancers can present as microscopic hematuria. So don't dismiss the fact that 5% of them could be presenting as such. A persistent recurrent hematuria can be related to a bladder inflammation. History would suggest that they've had previous chemotherapy or have previous radiation. And I was going to add a third reason for inflammation, which is the interstitial cystitis, to the slide. Urokinase is a normal enzyme in the urine. It breaks down the blood clots and therefore leads to clot lysis. Cytology is useful. It has a high specificity. And for those who have a very strong history, don't dismiss the cytology. The report is very clear. It comes back saying there's no evidence of high-grade urothelial carcinoma because cytology cannot pick up low-grade at all. Recommendation for our guidelines is to do a CT IVP or IVU. That's a CT urogram triple face with delayed images. Delayed images allows you to see the collecting system because you want to see a filling defect in the renal pelvis or calyces or in the ureter and bladder. Cystoscopy is essential for all hematuria cases, except when you think that you have been dealing with a UTI-related hematuria in its first event. Now, make sure that hematuria isn't a double pathology because there's a good reason why a patient could have both a stone and a cancer of the bladder. Medications can be related to hematuria, but this is actually just a red color in the urine as opposed to blood. So metabolites, food, and medications is a well-known fifth-year medical student quiz. The interesting slide is this one. Classifying blood in the urine is either visible macroscopic or macroscopic symptomatic or macroscopic with proteinuria or isolated. So you can see where we want to focus more on the top three. The single isolated microscopic condition can be ignored only if you can confirm the blood in the urine disappeared after the initial presentation. Macroscopic hematuria can be different colors. So I use the words cranberry juice to rosé to Shiraz to light rosé. So they can describe to you what they think is the color. And we use a dipstick in the practices these days, but still send the urine for analysis as well to confirm the findings. Again, the dipstick has its false positive, false negative rates. These are outlined in this quick slide. So ask in the history about vitamin C intake and check on the urine pH. Heavy proteinuria may suggest a nephrotic origin and can be a reason to quickly refer to a nephrologist for help. Microscopically, you can see that we want to see if there's any more than 3 cells in high power field. If we see red blood cell casts, that indicates most likely a nephrological or a glomerular bleeding cause. This is a nice acronym from Mudar. Thank you, Mudar. It's about the causes of hematuria, and the common ones are put first, period, prostate-related obstruction, nephritis, trauma and tumor. It's uncommon to see tuberculosis in Australia. And hematology reasons, you never dismiss a link between cancer and the use of blood thinners, infection, inflammation, and stones. And this picture describes most of the conditions which can lead to hematuria. Making sure the cystitis is one of the commonest reasons for microscopic hematuria in Australia. Renal causes, protein found in urine is an indicator of most likely a renal pathology. And so I quickly involve my nephrologist colleagues when I find proteinuria and a variety of cast cells. I won't take you into the details of that. Risk factors, you want to remember these factors would make you investigate the patient further and earlier than you would. For us, more likely than ever, number 8 comes into play. If a patient has irritative urinary tract symptoms, you have to think about carcinoma in situ, which is a flat cancer, same as pain, and if there's a history of previous radiation or in heavy smokers. So the significant hematuria is very interesting. It's a very nice slide. A single episode of visible hematuria, or a 1 episode of symptomatic non-visible, or a persistent asymptomatic non-visible on dipstick studies and urine analysis, all in the absence of transient hematuria. So if you have if there's no obvious transient hematuria brought by exercise, UTI, and menstruation, then these patients need to be investigated. In Australia, we always refer the patient if a persistent microscopic hematuria or macro has occurred. And this is when most GPs want to know when to refer. The 2 items is hematuria and high-risk patients. Nephrology referrals are triggered by the proteinuria, hypertension, and low filtration rate. Please do ultrasound whenever you have a high blood pressure patient, because you can always pick up a pathology quickly in the kidney if you do. Initial management, of course, you treat the UTI and you check blood pressure, check the proteinuria, check the blood tests, have a baseline creatinine to start with to know how much space you have to work on, and consider ultrasound imaging as a GP practice. This is readily available. And now most GPs also do move on to doing a CT IVU as well. Taking history is very important. You're focusing on all the signs of infection, the recent trauma, medical causes. And this is a very sophisticated slide. I won't go into most of it, but it has also a role to family history and how a history of polycystic kidneys and a Lynch syndrome, where there's bowel cancer in the family, can be related to kidney cancer as well. Investigations starts by history examination, palpation, and a DRE exam. We definitely want you to refer the patient and don't do maximum investigations beyond a single imaging modality, because we will definitely want to do some of our own tests, looking for upper tract imaging, CT, IVU, or MRI, urogram if he has a borderline creatinine. And therefore we try to avoid contrast, so MRI is slightly safer. And we check the lower tract with cystoscopy, which is now office-based and done under local anesthesia. We repeat the urine tests, and we also send patients for analysis, considering they may have other reasons for hematuria. And for those patients who we can't find a reason, we still want to get the GP to do a test in 6, 12, maybe 24 months, looking for a repeat UTI or an IgA nephropathy. And of course, consider repeating the tests in 3 years if they are high risk, like smokers, because in these patients, 3% of them who had microscopic hematuria will show up later as a urological cancer, and mostly in the bladder or upper tract. So the keys are to try to find early cancer, and if it's a locally controllable cancer, Ta-T1, as opposed to a T2 muscle invasive cancer. Alfred syndrome is a medical condition which has characteristics of renal impairment, glomerulonephritis, and hearing loss. And for those patients, we quickly refer them to the nephrologist. The signs we find are the alterations and the common family history involved. This is a syndrome which also is referred to the medical team, a combination of hematuria, renal impairment, and a variety of skin lesions. For those, I don't treat those patients. I refer to the nephrologist. I think it's beyond our scope as surgeons to treat those patients. But for the hematuria as a presentation, this is our commonest presentation as an emergency beside torsion. And for those, we have to help the blood transfusion if required for heavy bleeding, control the reversible causes of hematuria like infection, a 3-way catheterization, irrigation, and emergency, And we use a variety of simple measures to control the bleeding, mainly by irrigation, traction, and sometimes embolization. They often end up going to theater and have diathermy of the bleeders. And then we use medications to control long-term bleeding. This condition is quite rare, thankfully, because of the awareness of how it arises. We're seeing them in the old generation of radiation patients who had higher dose radiation before the IMRT methods. For those, we have a dilemma because we have so many, hopefully somewhat useful methods, but in reality, often all of those methods would fail. I've had some success with the oxygen hyperbaric chamber, but it's not available in every capital city, so we don't have that much. Intravenous therapies for refractory, retractable hematuria radiation type could respond to aluminium, alum, and we have a protocol for aluminium. Tranexamic acid can also work. It's slightly weaker in effect to other methods. Oxygen has been available in Sydney. We refer patients to Sydney for a lengthy session and for 40 dives followed by a review, and can take up to 2 years to control their ongoing hematuria. And that has its own contraindications. I have been using the 3-way irrigation method and using local vasoconstrictors with aluminium because of its protein denaturation effect. Most pharmacies in hospitals have it. It's run over 36 hours to 3 days and has no reflux risk, while formalin is, I believe, obsolete, and it's a very dangerous drug to use. If you can avoid formalin by any cost, do so. Silver nitrate has been used as installation. And I've now used this medicine early in radiation cystitis. It's available as a pre-filled syringe. Pharmacies supply it. It has a combination of glucose, aminoglycan replenishment layers, chondroitin sulfate, and hyaluronic acid. And it's now available also as a capsule gel to take twice a day for 3 months. Thank you very much.
Thank you very, very much, Dr. Ahmed. Very nice. So just a couple of housekeeping before we sink into the questions. I think I received a message from the background from the Zoom saying that for a problem for the first, I think they described 3 to 5 minutes that the recording was not optimal. So if everyone agrees that since we're doing very well time-wise, due to the speakers were very prompt, may I kindly just ask, perhaps let's call it the first question that Dr. Mulher, to just quickly summarize your treatment options for irritable bladder, starting from the conservative method. And one of the questions from the audience about the bladder diary and what is the best way of explaining it to the patient? Sorry,
bladder,
go ahead.
Yeah, thank you very much.
Thank you.
Yeah, bladder diary is an important part of management because it gives us an idea of what's happening in the bladder. There are approved forms. You can just Google it and get like I've attached a example of it on my presentation. I'm happy to share what I use as a bladder diary if anyone asks, but it's readily available. The problem with the bladder diary acquisition is that patients are not going to take a jar of a jar and wee every time they go to the toilet and at their workplace, especially if they're a bus driver or something. So usually they will do it over the weekend, but it's not optimal, but it's usually that's the best you can get. You just get them to get a 2-liter jar from the $2 shop, and they wee in a jar, and then they weigh how much is that, and they measure every time they wee. They measure how much they wee and then record it in that summary. They also need to record any what they drink, coffee, tea, and what they feel when they have the urge. Do they have the urge? Do they have a leak? And that accumulated into a good idea, subjective, of what is happening in their bladder, objective, what's happening in their bladder. There is also some apps that you can get. Most of them are free, and that can be a lot more user-friendly. So you don't end up with a paper with a coffee spot on the middle, because that's what I get.
Good. Thank you very much. And although you guys have explained about nocturia, so can you just simplify it a little bit more? So what if a patient wakes up, say a male patient, wakes up once in the middle of the night for the toilet? Are you interested as a disease or not yet?
So it depends on, there are multiple factors of why patients wake up at night, especially in elderly population who they don't actually get a full night's sleep because they have a siesta in the afternoon. Usually 2 episodes of waking up from sleep, they start to get significant. Usually you're interested in the hours in uninterrupted sleep because that's the important quality. And last but not least is, are they bothered? Because if someone's bothered with one episode of nocturia every night and it's affecting his work because he's a pilot and he needs to be at optimum, is different than someone who, yeah, I've been going to the toilet 3 times a night for the last 10 years. I'm comfortable with that. So these are the factors.
Wonderful. Thank you very much. I do have as well another question. You mentioned nicely the anticholinergic versus beta agonist. And so do you put a cystoscopy with the Botox as a valuable option to them, or you sort of talk to them to try the conservative management first before that?
We're limited by the MBS recommendations. You can officially, you cannot give someone Botox unless they fail at least 2 second lines. So we have a stepwise pattern: lifestyle changes, medications, and then failing medication moves you to the next option, which is the Botox or Sacral Neuromodulation.
And if they qualify for that, is it rebatable in a public hospital versus private hospital, the Botox?
So the Botox is rebatable. It's available. It's most hospitals do use that as their preferred 3rd line option, because the Sacral Neuromodulation is so costly. In the public system, they are available, but they're usually limited by budget. And in my hospital, I think we have an allowance of 4 sacral neuromodulations a year for a population of about 1 million people.
Yeah. Can a patient choose a cystoscopy Botox in the private sector? Say, I have a private cover. Can you just take me to the private to do that? Or still the Medicare will question it?
I think the Medicare will question it in that term. And even in like the management option, you should not be moving into a more invasive option unless you exhaust all the non-invasive options.
Sure. Excellent. I would stop here. Any questions from the audience, please perhaps either put in a chat or raise hand. And Dr. Ahmed, go ahead, please.
Thank you very much. First of all, thanks for Dr. Ahmed Samarai and Dr. Model for the excellent and very precise, to the point presentation. In fact, we were struggling as a physician to finish the presentation in 1 hour. Now we have our urology colleagues finishing even before that's the plan. Now I have few questions. The first one is regarding the Botox use. In gastroendoscopic intervention, we use Botox for a variety of indications, like achalasia or like gastroparesis. But we know for sure that the effect of Botox is very time limited. In the best circumstances is 6 months, and we need to repeat the procedure within the 6 months. Does this apply to the treatment of irritable bladder or nocturia?
So for the Botox, depends on the cause of the bladder problem, and is it idiopathic or neurogenic? And it differs from one patient to the other. So usually it carries from neurogenic, it takes up to 6 months, and then they start to have the symptoms again. And usually for idiopathic, it carries on to about a year. You don't know till you see them. So what I tend to do is I tend to see them about 4 weeks after the induction or after the initial Botox. the lesser known fact that the Botox doesn't work immediately. It works 2 weeks later. And that gives me a very good indication. If it works immediately, it's a placebo effect. If it works 2 weeks later, it's actually a real Botox effect. And I see them then about 3 or 4 months later, and that will give me an idea whether they are withering down the response or whether they are actually persistent, and I will delay their further Botox. These guys keep coming back, and then you establish with each patient a pattern. This patient is a 9 months patient. This patient is a year patient, and then you can put them on a regular schedule. And if they have any problems, especially with the public hospitals, when we say 3 months, it's a really 6 months and a half, they can revert back into their medication to bridge them through till we get a more established pattern.
Right. Thanks.
Thank you very much. Perhaps I have, if there is no question from the panel, as we have still a few minutes. Okay, Dr. Majid is raising hand. Go ahead, Dr. Majid, we can hear you.
Can you hear me now?
I do hear you. Go ahead, please.
Okay, thank you very much. Thank you للمحاضرين الكرام، لأن موضوع جدا مهم ويهمنا احنا كبار السن مثل ما نقول. وسؤالي أو مقترح على البامكن سيد، اكو فد ريسيرش او فد شيء من هالقبيل هذا او فد دراسه معينه لهذه السيد، لانه عمليا طبقت لاكثر من بيشنت جود ريزلت. ماذا يقترحون الاساتذه؟ احنا هسه متقاعدين، فشو يقولون الاساتذه؟ اكو ريسيرش او مفكرين بهالموضوع هذا وهذا يوسفول؟ Thank you very much for both.
I might take this one. I might take this one. So مشكور. هتكلم بالانجليزي، معلش سامحني يا اخي العزيز.
براحتك. Same. English, Arabic, as you like.
هتكلم بشكل. There's a large number of papers about the role of natural therapies, and currently we do believe in a role for pumpkin seed extract and special herbal plant extracts like saw palmetto, which is an extract from an African tree called Serena ripens. Also the role of selenium, and there's so many of these options available. And yes, the first thing we should try is always natural therapy in the mild cases. Just last week, we got the publications about the alpha blockers, and the recommendation now is not to take alpha blockers long-term because they have been linked to congestive heart failure. So definitely, if you look at the long-term data for benign prostate hypertrophy, the recommendation is now that alpha blockers have been related to early signs of congestive heart failure and are best avoided. So if your question becomes now, what do we do for benign prostate hypertrophy? Patients who have symptoms which have led to nocturia, the need to wake up at night frequently, we have to first rule out that there's other important causes for nocturia and not just the benign prostate hypertrophy. And amongst them is the fluid balance, the reverse diuresis, the shifting of fluids at night, the need to wake up because there's extra noise in the house, or there's some early signs of congestive heart failure, those who are on CPAP machines, and those who need to wake up for a dry mouth. So there's so many reasons why nocturia happens, and the commonest is the natriuretic peptide response of congestive heart failure. And now we say to someone who wants to address nocturia at night is go and do some exercise before bedtime for half an hour, like a pedaling of the foot near the bedside. And this exercise shifts the fluids away from the third space back to the vascular system, and he therefore passes more urine, allowing him to be shifting the fluids away from and earlier from the heart and the kidneys. Or changing the diuretic timing. If he's on Lasix, you change the timing of diuretic. If you can change the cardiological input to treat the heart failure better, then that's recommended. And do the ultrasound, because ultrasound post-void residual tells you how much the capacity of the bladder was before emptying, and after emptying. And this is the functioning capacity. And then what is the residual volume? And remember, doctor, we make 0.5 ml per kilogram per hour. So if you actually have a bladder which empties down to 200, you've already got 4 hours in your bladder when you go to bed. So you'd rather have a way to empty these 4 hours better to 1 hour worth of bladder volume and then go to bed. So the idea is if you can empty your bladder fully, that's great. If you can empty it to 90%, that's fine. And if you can't, but you can reduce the sensation that wakes you up at night from it, then you can try that too. It's a matter of looking at the functioning capacity and looking at the emptying efficacy of the bladder. This is why many patients want to come and see us, and we do a urodynamics to see that they have a subtle bladder obstruction at the bladder neck or the prostate. And now we have so many new methods, which are minor procedures to fix the prostate outlet without a major surgery. They're called minimally invasive treatments. And they range from inserting a small stent to a temporary stent to a device called the prostate lift to injecting steam. مي حار 104 مئوية 9 ثواني في البروستات بالجهتين. البخة مالت المي الحار اللي هو مغلي من يرجع للمي الاعتيادي ينطي الطاقة مالت البروستات. فالبروستات تتعرض إلى شد حراري with a radio frequency ablation, which will remove or destroy the tissues in time. بس يحتاج 3 months to see the results. فهذه عمليات تجرى هسه على كبار السن اللي ما يتحمل تخدير، ننطيه بس sedation لمدة 10 دقائق أو 5 دقائق ونخلي هاي البروستات ليفتس ونحسن موضوع دفع البول.
I think it's better than chemotherapy and radiotherapy because I worked in nuclear medicine in Baghdad for 24 years, dealing with the patients who have cancers, sometimes other illnesses, and so on and so on. So I haven't seen the patients who took the chemotherapy or radiotherapy very good results. That's what I mean.
Prostate cancer is a different subject. موضوع cancer prostate احنا ما تطرقنا له هسه لحد الان، حنتطرق شوي بعد ثاني الدكتور. بس التضخم الحميد هو اكثر شيوعا ويحتاج الى علاجات بسيطه اذا امكن.
Okay, thank you very much, Doctor.
You're welcome.
Wonderful, excellent. That's great so far. دكتور أحمد, go ahead, please.
دكتور مهند, احنا اكو عندنا اتفاق ويا دكتور أحمد السامرائي. نساله بعده يتذكره. كان اكو اتفاق دكتور. كان اكو اتفاق الدكتور يعني highlighting something about prostate cancer and the PSA in particularly. لأن في يعني هناك a lot of practical implication on the side of general practitioner.
Well, Dr. Ashawi also was very happy to present a small presentation about the subject.
Okay,
I think it's ready.
Excellent.
Dr. Ahmed Al-Rubai, we as surgeons are very clear people and straight to the point. So dissimilar to the physicians. Dr. Mudhir told me before we started recording that there is a bit of a summary available on the prostate. If it is the case, Dr. Mudhir, would you please go ahead and share your screen again if you don't mind, or you can go verbals, up to you.
Yeah, so can you hear me? Good. Yeah, this is a last minute request. So I made a compounded, just a quick summary about what's the latest on what has changed. And to talk about prostate cancer, I think we probably should have for a full second session about it, but I'll just touch base on the new paradigm shift in prostate cancer. Because over the last 10 years, we now diagnose prostate cancer better and we treat it better. And that breaks down to simple things from changing our nomenclature from what we call a Gleason score, which ends up with 3+4 or 3+3 or 4. And this is very confusing for the patient. And we moved into what we call an Isop scoring system, which brings it down to Isop 1, which is Gleason 3+3, Isop 2, which is Gleason 3+4, Isop 3 is 4+3. All 8s are boiled down to Isop 4, and all 9s and 10s are Isop 5. So when I tell the patient, you have a 3+3 prostate cancer, they'll say, oh, what does that mean? When I tell them it's PSA, you have a Isop 1 out of 5, it makes a lot of sense. We classify them better, because before we used to say low risk, intermediate risk, and high risk. Now we move into the super low, low, intermediate, favorable, intermediate, non-favorable, high risk, and very high risk. Now, this is from the diagnosis and the PSA. And when do we do the diagnosis? When do you investigate? That's the whole talk, and I'll come back to that. But from there, if you have someone with a prostate cancer, the suspicious of raised PSA, we have the luxury of doing an MRI scan, and that gives us a more of a visual reflection of the prostate cancer. And that's been developed over the years into, yes, there is probably a cancer, and that's, again, 5 pyrite scores of 1, 2, 3, 4, 5. 1 and 2, no cancer. 3 is equivocal and usually carries a risk of 30% of cancer. 4 carries a risk about 70% cancer, and 5 carries a 90% cancer. With that, will give me A, who do I need to biopsy? B, will give me a target of the biopsy. And gone were the days when in Australia, we do a transrectal biopsy. You go through the bum with all the poo and all the pus, and you go through the prostate, and you're asking for trouble, mainly sepsis. Nowadays, we do transperineal biopsy, where we go through the skin of the perineum straight into the prostate, avoiding rectum altogether. Once we diagnose them, what do we do with them? Back in the days, we used to just take the prostate. Oh, it's cancer, take it out. Now, more and more, this is the big shifts now. More and more about active surveillance. Young guy, low risk, just monitor them. Don't do anything. Delay your intervention, because intervention has a high toxicity. Erectile function, continence, big surgery, radiotherapy. Our dear colleagues have explained it's hard on the patient, and these are big impacts. So we avoid doing that on low-risk disease patients and ultra-low-risk patients. But we monitor them like hawks, and when they develop into the more aggressive stage, then we interfere with treatment. PSMA PET has been very valuable in actually identifying which one actually had a metastatic disease. So we don't subject people to a big intervention, then ended up saying, oh, sorry, it's already metastasized. Moving into the next limb, which is the robotic surgery. We got better at the open surgery. The results are getting somewhat better. Robotic surgery is the new kid on the block. It's sexy, it's low impact on the patient. Yes, they do cost. Yes, there are some studies that compare them to open surgery in types of results. But I think this is very, very surgeon dependent. And I think we are the last generation to be trained in open prostates. And the next generation of urologists would not know how to do an open prostate. And last but not least, with people who are high-risk prostate cancer, we used to give them adjuvant radiotherapy up front as a top-up. But now we're realizing that we can delay that till they have a raised PSA. And we say, oh, now we can treat them with salvage radiotherapy, which saves over treatment without compromising overall survival. Sorry, this is a very short presentation of a subject. Like my personal presentation of that subject for my study is 350 slides. So I'm sure you would not.
We'll have you We will have you on another day, Dr. Mudhir. Well done.
It would be a pleasure. Me and Dr. Ahmed will have a pleasure of having this conversation.
Yeah, both of you. I mean, both you and Dr. Ahmed. Can I ask a question here, if there is no other question?
Sure.
Go ahead. Go ahead.
Okay. Dr. Ahmed, Dr. Mudhir, two questions. First of all, the specificity, the current specificity of the PSA, that one. Two is for male screening. You know, for bowel cancer, once male hits 50, we start the fecal occult blood testing. And this is now, there's a program, the National Bowel Cancer Screening Program, that every or most houses receive this kit. So is there any set of age that you recommend screening males for prostate cancer?
So Victoria has been the guiding capital of the world in that. So I'll give it to Mudhir, because they actually have a very good pathway, which is way beyond the American pathway. And we are beyond America by almost 5-10 years because of their work. Thank you, Mudhir.
Thank you very much for the question. So I think the key aspect is, gone were the days when we judge their patients by their age. So the PSA is a tool. It's a screening tool. It's rubbish, to be honest, but that's the best we can. And we have. But when do we start? We start, depends on how did they have high risk family? Did they have a standard risk? And that's between 50 years of age and 55. When do we stop? We stop when there is no point of doing any intervention. So why do the investigation? And that usually boils down to 10 years of overall survival. So if you have a patient, then I use like the Charleston Mobility Index. There are a few calculators. And then there is the eyebologram. You look at the patient and you know what, man, you're not going to be here for 10 years. So let's not worry about the PSA. Now, the Prostate Cancer Foundation Australia has a very strict recommendation and a very good guidelines, and I'm happy to share what they recommend. And in the field, the PSA, do we do them? Do we not do them? I know the GP recommendations been changing back and forth. The Americans have led some campaign against PSA based on a flawed study called the PLCO, and that's been debunked. But it's still a treacherous area. So the summary of the recommendation from the Australian Foundation is community-based wide screening is not recommended. However, in a patient with more than 10 years of life expectancy, the PSA should be discussed. And in taking into consideration the benefit, including early detection, early management, versus the complication and the side effects, including the anxiety, over-treatment, and the toxicity of the treatment. So it's a discussion, and start with the GP, start with you. And the more you know about the subjects, the more I get to help people, rather than have someone with 3 relatives with prostate cancer who never had a PSA check versus someone who's 85 and, you know, with a terminal cancer and still, oh, I get a referral, he has a high PSA. So dissemination, that knowledge is important for us. And from there, the cutoff points are specific, and that is another detail, but usually care is done between, I get worried, I mean, anybody below 50, I get worried with a PSA of 2. Anybody above the age of 50, my cutoff point is 3 for further investigations.
I completely agree. The Melbourne team suggested that we should do the PSA from 45 to 50. If it's above 2.5, but under 4, do it every year thereafter. If it's above 4, that has a sensitivity, which is quite low, 21%. But do the ratio. And I'm very unhappy to see GPs do a PSA. It comes back as high, H. And with the ratio under 10, and they don't refer him. Don't do a finger test. Remember, the finger test with the PSA together can be very much useful for us. The more finger tests you do, the more you will learn what the finger test means, right? So I still see patients who get referred not to me, but to the MRI after 4 high PSAs. Every year, the patient goes from 7 to 9 to 12 to 14. He does the MRI, and the MRI calls me saying, doctor, this guy has bone cancer. Where are you? And I say, well, I have no idea who he is. So the PSA has been a disaster for us, but because we have been using it as a replacement of common sense, of finger testing. So if the PSA goes up every year, don't wait, refer to us. We have stopped seeing T3 cancer, prostate, from 1995, thanks to the PSA. Because now, when the PSA is 40, everyone runs to the doctor and says, let's go and see the patient quickly. But PSA 40 is gone. PSA 100 is gone. Is it really gone? Not quite. We can still offer them multimodal therapies and survivalship, but we can't cure them. So please, my message today is, if the PSA is high by the lab H letter, send to us. If it's high with a ratio under 20, send to us. If it's a ratio under 10, I can guarantee you he must have an early cancer prostate. Get the MRI and send to us. And if you have doubts, some variants of prostate don't make a PSA. 10% of cancer prostates don't make a PSA. So you can't use the PSA as an indicator. For those, you have to use your common sense. A prostate size increasing on MRI from 40 grams to 60 grams in a year. Why? Let's check it. Let's do a biopsy. The finger test can't examine the anterior zone. That's a region the finger can't reach. So if we can't reach with the finger, let's do the ultrasound. And I'm very pleased to announce we've received the new high-powered ultrasound, which will replace now the MRI. So the new advancements in prostate cancer will be the newer ultrasounds, which are office-based with transperineal biopsy, like Dr. El-Shawi mentioned, office-based, which are typically ideal for the small prostates in the office. Why would you have to give anesthesia for a transperineal biopsy? You do a filtration anesthesia to the perineum, you take the samples you need, and you have the guidance because you're going by the MRI definition. The MRI would say, look, the left apex is 20 millimeters suspicious, high score of risk, we biopsy it. We can give the patient the answer on the spot. I just saw a patient from Wagga Wagga who's 70, who just married a new Filipino, and he's here for a PSA of 7, but no one did a PR exam. Even the urologist who did a cystoscopy a year ago didn't do a finger test. And I examined him, and he's a T4 disease. Biopsy in the same day from Wagga Wagga, same day biopsy, glycine 8, 4+4 in all samples. What do I say to this guy now? I can't cure this guy, most likely. He's going to have a scan, a staging. So definitely don't take the PSA as being the one test only. The PSA and the breast mammograms were both done at 1995, but the breast mammogram failed to prevent progressive breast cancer. The PSA succeeded in dropping down T4 disease and T3, but we're still losing patients for the same reason. The same PSA inventor regrets that he actually invented the PSA, but he's saying, look, it's not my fault. It's like dynamite. I make dynamite for you guys, use it for war. So PSA.
Excellent.
Wonderful. Wonderful. Thank you very much. Just checking if there's any other questions from the audience.
With the prostate cancer, we'll see multimodal therapy coming strongly because we are still seeing advancing cancer in high grades. PSA non-producing cancers, cancer in the anterior zone, cancer in the rapidly progressing methods. Young patient, 49, and within one year, his PSA goes from 4 to 7, but his PHI goes to 103. The PHI is a slightly better test, Prostate Health Index. It's a blood test sent to Brisbane. If your PHI is very high, take it seriously. The PHI is an algorithmic number, which takes the PSA, the free ratio, and a third protein, and the algorithm is very important. So don't dismiss a PHI above 100, just like you don't dismiss an ESR of above 100. The PHI is very important. If it's above 100, that patient is guaranteed to have a cancer and take off.
Wonderful. And where can we find the PSA guidelines, Dr. Ahmed?
So the PSA guidelines are found on reputable websites. We have the Urological Society of Australia and New Zealand, the USAN's website, and they have the PSA guidelines clearly outlined there. You also have the PSA guidelines from the Urological Society of America, so American Association, AUA, under the word urologyhealth.org. And that would be a very good website for the patients and for the doctors to look at, urologyhealth.org. It's the American Urology Association Foundation.
Wonderful. Thank you very much. Perhaps as there is no more question, I have just one last question, perhaps to Dr. Ahmed and Dr. Mudhar. Public patients, they can't afford the private. They cannot afford the neat robotic surgery. Equality and fairness. Do we tell them that perhaps a good laparoscopic prostate surgery in the public is equivalent to robotic surgery?
Thank you. There's three types of surgeries: open, total, or radical, laparoscopic, robotic, and laparoscopic non-robotic. Most of us haven't been trained to do laparoscopic non-robotic because it's a very skillful operation. It takes many years of training to achieve the results we need. So you're right, we will not have enough people trained to do open radical in the future. However, we are seeing a drop in the costing of robotic with time for obvious reasons. And so we'll see more patients having and affording to do robotics in the future. And explain to the patient that the penta factor of robotic is 85%, while the open or the non-robotic can't deliver more than trifactor and only 55%. Trifactor is cancer control, erectile function preservation, and continence. The pentafactor for robotics is 83%, and it's cancer control, continence, erectile function, bladder neck toxicity, and anastomotic problems, and blood transfusion. So you have a patient who you can tell him, you can guarantee him this car will last you for the next 10 years because you've given him 82%, while this guy has, you sold him a car, but will be guaranteed to break almost always, or go back to the servicing in the first year, almost always. So you say to the patient, look, honestly, open surgery, the good surgeons who are trained to use it and do it are still doing it well and widely. And there's steps in the surgery you have to abide by. But I have been treating now patients for the last 7-10 years who are disasters of open surgery. Because in many centers, they are given to the most junior of the registrars to do. The registrar does a good job, the patient recovers, the registrar goes to the next center, different state, and the patient comes back to me with incontinence, radiation for cancer control led to stricture, anastomotic leakage leads to contracture, contracture leads to SPC, bladder capacity is lost, compliance is gone, and he's now a patient who's a burden on his loved ones. Not to mention he's lost erectile function thanks to the onset of hormone therapy. He's on castration medicines. So never take the surgery as granted. The apex of the prostate is a very delicate area where sphincter function, nerve preservation, and cancer control all come together in the same area. It's a very, very delicate area to operate on. And we seem to give it often to our most junior of registrars, not thinking that this is the most important part of the surgery.
Perfect. Thank you very much. Hopefully we see the robots coming to the public in a few years' time, as now perhaps the companies, J&J and others, are competing with Da Vinci, trying to deliver cheaper and cheaper options. And perhaps that will be a win-win to training public patients and everyone. If there is no more questions from the audience, I would sincerely thank our senior presenters, Dr. Ahmed Samarai and Dr. Mudhar Shawi. You made a very complicated subject look easy and easy to understand when it's not. So I'm grateful for your attendance and delivery of massive information nicely and simply over 60 minutes time. And everything of that lecture will be hopefully available on our YouTube channel very soon after we receive the recording from the Zoom. Thank you, everyone. Thank you very much. Dr. Ahmed Rubai, do you have any comment?
No, I just would like to join you thanking Dr. Ahmed Samarai and Dr. Mudhar. A special thanks to Dr. Ahmed Samarai for another actually level of help. Dr. Ahmed Samarai is very helpful whenever we got to consult him on any issue. And in fact, he replied in no time to any inquiry through emails. We receive inquiry from Iraq, for example, on difficult cases, and we try to help from here. And we try to direct our inquiries to our specialized colleagues. And Dr. Ahmed always reply in no time, in fact. So many thanks for him for this, and many thanks for Dr. Mudhir for helping us in this forum. And I hope we can have them in another events.
Thank you very much.
Absolutely. Once we cover these specialties, then perhaps we'll approach our urology colleagues again to deliver different subjects, hopefully in the near future. I don't see the face-to-face meetings are coming soon, so I think we will renew our membership with Zoom.
All right. Thanks, Doctor. Thank you very much.
Thank you very much. Thank you, everyone. Thanks a lot.
Thanks.
Bye-bye.
شكرا جزيلا.
شكرا دكتور. شكرا عزيزتي. ألف شكر. ألف شكر.
روعة.
Dr. Rafi Khoja. Can you hear me? No, he can't. He mute himself. That's right.
نعم دكتور أقدر أسمعك.
عزيزي دكتور احنا يعني نرحب بك، بس انا ما اعرف انت الايفنت شلون عرفت بيه يعني بيرسونالي، لو انت ضمن الجروب مالتنا مال.
انا استلمت ايميل من الجروب.
من الجروب.
جمعيه.
بلي.
دكتور انا اشتغل SRMO ببانكستاون امرجنسي، ومرات احكي وياك من يكون ادميشن تو جاسترو.
اهلا وسهلا.
يكون عندي نايت شيفت.
اهلا بيك. اهلا
يا هلا.
ان شاء الله نلتقي بالمستقبل
ان شاء الله يا رب. شكرا.
اهلا بك. اهلا وسهلا.
شكرا جزيلا على التوبكس الجريت توبكس.
واحنا بالخدمه. اي سؤال الشباب، اي استفسار، تليفوني موجود.
تسلمون. شكرا جزيلا. تسلمون ما بقصرون. شكرا
استاذ احمد. شكرا موصول استاذ مظهر. ممنونين جدا. شكرا جزيلا.
شكرا جزيلا.
عايشتكم على هالاجتماع.
شكرا.
خير. مشكورين.
مع السلامه.
مشكورين.